If you guys don't know about, we are GEM Physio, Global Initiative for Expert Manual Therapists. We teach a 1-year diplomat program. We also teach online. We are starting with our cohort 3.0. Last month, we were in Delhi and Bombay teaching a 1-week workshop. If you guys attended it, if you have more questions about our cohort 3.0, which we are starting next month, you can reach out to Dr. Dhumi. She takes care of the admin stuff. Okay, you can see the eligibility criteria on the screen. We're going to be talking about, this is me, Dr. Tejinder Singh, and I have Dr. Stephen Ford. He's my co-founder. Okay. Okay. We're going to be talking about a very complex patient I saw in the clinic. I think I started seeing her in January. She's here with me. Okay. My patient is a 25-year-old female. She came to me with low back pain, left hip pain, numbness and tingling in bilateral anterior tibia. She had a fall in February 2023, but she reported that symptoms became really worse in the last 2 months. The interesting thing here is that she had on and off symptoms for almost 2 years, and she's seen a bunch of providers, few medical doctors. She also has a medical doctor in the family. His uncle is a physician. So she got like wide variety of medical opinions. And when I started seeing her, I mean, I think she had a lot of misconceptions. A lot of interesting advices were given to her. And so actually, I'm going to give her opportunity to speak here. Okay, she's going to come and talk about, I have seen her for almost 12 to 16 weeks. So she's been with me for almost 3 to 4 months. And I mean, she's doing really well now, but she's going to be talking about how she presented, because I think it's interesting to understand that she had a lot of symptoms in the leg. I can show her pain chart. So this is what she filled out on day 1. Low back pain, one-sided hip pain, pain in bilateral shin. Okay. And numbness, a lot of numbness, tingling in bilateral shin. But most of the severity was in low back and hips. Okay. I will give her opportunity to speak, and I think she'll be talking about how she presented with on day 1. Okay. Do you mind coming here, Mariana, and just talk about it, talk about this, talk about your history, detailed history.
Hello. So 2 years ago, I was working at a neuro rehab place taking care of patients. And long story short, I got an injury, and I was told by the doctors that I had a herniated disc and that my disc was degenerated. So this was 2 years ago. And ever since then, I just assumed that I had to take care of my lower back, just protect it and do certain things. I avoided running, and one of the doctors told me I couldn't do a lot of horseback riding and skiing. And then a year ago, I fell down the stairs in the ice storm, and I had a really bad tear in my muscle, but I never got treated for it. And throughout this year, since then, I've had a couple of symptoms I just avoided because I thought it was my disc injury for some reason. I had a lot of shin pain, and when standing for a long time, I felt really weak. And after a long workout, I felt like I couldn't stand. And this was for the past year. And I even went with a doctor, and she told me I had a muscle imbalance, a hip imbalance, but I never really addressed it. So around 6 months ago, like 2 months before I started seeing TJ, that's when I started feeling more symptoms, and that's when I decided to reach out for help. I started feeling numbness specifically in my shins. I started feeling lower back pain and shin pain too. So I just assumed it was my disc, and I reached out to doctors, I reached out to like 5 doctors, and either they told me that I'd to take ibuprofen, or that to do physical therapy. And I also saw another PT, and everything, all the exercise she was giving me, it just made it worse. So throughout those 2 months before I started seeing TJ, everything got worse. I had really bad pain in my lower back. I think the worst part was just it got to a point where I felt like I couldn't sit or stand or drive because of how bad the pain was. I got an MRI in my lower back, and the orthopedic surgeon, he told me that my disc was good, that the whole symptoms, it wasn't my disc, and my leg symptoms could not be explained by my disc. So I ruled out the disc for this cause. And then, yeah, this beginning of this year, that's whenever I came to TJ, and he diagnosed me with SI dysfunction. And then, yeah, it's been 4 months now since then, and I've slowly gotten stronger. Right now, I feel really strong. I think the strongest I've been, even months before starting seeing TJ. Like, I think I feel stronger than a year before. I think this whole thing has been going on for a really long time. I just didn't really address it, just because I thought it was my disc. And yeah, I thought it was my disc, and I thought I would eventually, in my mind, I was like, if it gets worse, I just have surgery, because I didn't know what was going on. But yeah, overall, I'm thankful for getting stronger and for finding out what it was. And yeah, now I'm able to live a normal life, and I'm very thankful for that. Thank you.
Okay. So I think this was the detailed history. I think the idea here is that when you give patients a certain advice, it impacts them emotionally, it impacts them psychologically, and that's why clinical reasoning is the key. I mean, you have to understand where the symptoms are coming from. If it's numbness, tingling down the leg, as in her case, it's not necessarily the disc. I think we're going to talk about this patient because there are multiple layers to her symptoms. So she has low back pain, pain in the hips, pain in the SI region, and then she has numbness, tingling. So, and it is hard to explain if you have like these many symptoms, because each symptom has a cause, and to find the cause, I think you need to assess very accurately. And that's, I think, and still clinical reasoning is the key, because if you can, I think there should be an explanation to all her symptoms, and it's definitely more than one pain generator. So if you're having numbness, tingling, you're having pain in the hips, pain in the back, there is definitely more than one pain generator. And I think when you have this level of complexity, you require higher level of problem solving. Okay. So, okay, she was taking some medications. I think this is what she filled out on day 1. Her goals were alleviate pain in the back, lower legs, strengthen, gain mobility in core, low back, strengthen, gain mobility in the lower legs. She's a very active person. She goes to gym like 5-6 times a week, at least she used to. So she's a very active person. And I mean, I think this episode really affected her. So, okay. Previous medical diagnosis, I think this was made on an MRI. She has seen like 5 physicians. So everybody has told her different things. At one point, she was told that she has degenerative joint disease, disc herniation, slight narrowing at L3, L4, L4, L5. Okay. And she was advised to abstain from any high impact activities running for rest of her life, which is actually very stupid. So if you can't tell your patients that, you're 23 years old or 24 years old and you won't be running or doing any high impact activities for rest of your life. Okay, that makes absolute no sense. Okay. Okay, this was the pain chart she filled out on day 1. Okay, we'll try to do a little bit of problem solving here, try to understand why she's getting these array of symptoms. Okay, we'll do an objective exam, and then I'll show you how we addressed her symptoms. Okay. Okay. And this is not a very, very common patient presentation, but I think once in a while, I think you'll see this. Okay. So this was the pain chart. So make sure that you understand where the symptoms are. Okay. So if I have to superficially look at it, okay, bilateral symptoms, I would think, oh, so she's probably getting some L4 compression. And so basically she's getting like L4 because she's getting bilateral symptoms in L4, right? And if you do MRI, MRIs will show some false positives. And if you have narrowing at L3, L4, L4, L5, you'll just think, oh, this is L4 disc herniation, giving her numbness, tingling. And that was one of the medical advice given to her. But that was not the case. Okay. Okay. So we did objective findings. I think we filled out a lower extremity functional scale on day 1. I filled it out for her. She scored 25 on 80. If you have attended our foundations lecture, I love this questionnaire because it has a lot of reliability. Okay. I think reliability is 0.98. Okay. And if you're looking for difference, I mean, you look for a difference of 9 to 10. Okay. So she filled out 25 on 80, which means I would say it's like 70% disability or 69% disability. Okay. You can multiply this by 100 and then subtract it from 100. Okay. Lumbar range of motion, I think she was restricted in extension primarily. Everything else was okay. 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 We did a lumbar palpatory exam. I did not find any dysfunction above L5, but L5S1, I was finding some dysfunction because left transverse process was prominent with extension. So I'll demonstrate this, how we did it, and we'll go through series of steps. I'll try to demonstrate everything we tested on day 1. Okay. 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 Maria, do you mind laying on your stomach for me, please? Okay. Okay. Yeah. So this is a test we do to assess if you're trying to find a dysfunction in the lumbar spine. Very, very simple test. All you have to do is find L5S1. Okay. I found like L5 transverse process to be prominent. And if you ask the patient to extend, do you mind lifting up your chest? Lifting the chest. Yeah. Ideally, what should happen is with extension, the transverse process should go deep. Okay. But with extension, it stayed prominent on the left. So it stayed prominent on the left. And that explains that there is something going on at L5S1. You can check L4, L5, L3, L4. Everything's looked normal above. But L5S1 stayed prominent on the left. So L5 stayed prominent transverse process. That says that it's not closing properly. Okay. You can call it a closing dysfunction, or if you're trained osteopathically, you can call it an open dysfunction. Okay. Okay. Because her symptoms were a lot in the SI region and in the hip, I definitely like to test SI cluster. I think we talk about in the pelvis course all the time. And the crazy thing was every SI test was positive. So if you look at the data here, the sensitivity is 0.9. This is from Laslet 2008. If it's greater than 3, the sensitivity is 0.9, specificity is 0.78. But in her case, all 5 tests were positive. I'm going to quickly demonstrate these tests. They're very, very straightforward. Yeah. Get reminding on your back for me again. Yeah. Yeah. So you can do a compression, which is nothing but like this. I think if you look at the Laslet article 2008, he did the compression in side lying. I don't think it makes a huge difference. You can do a distraction. Okay. You can do a thigh thrust, which is nothing but you do a flexion, a little bit of adduction, and then just push it down. That's thigh thrust. Okay. Okay. I'll just show the Genslean because it's done in supine. Just go towards me, please. Okay. And what you do is can you hold the leg for me, please? Can you hold the leg for me? Okay. And this is like a Thomas stretch test. Okay. And this is all of this is done on the left side. Okay. And then there's a sacral thrust. Lay on the stomach, please. Okay. Sacral thrust is nothing but you're just trying to push on the sacrum. Okay. Kind of doing a PA. Okay. If in her case, everything was positive on the left, and the symptoms, the severity was a lot on day one. She was reporting a whole lot of pain. You can see the VAS is 2 to 9 on 10. Okay. Okay. So we found a lumbar dysfunction, and then I kept hunting for SI, as we always do SI cluster because this is gold standard. And if 5 and 5 are positive, we definitely know the involvement of SI joint, right? Okay. And then we do another cluster. This is given by, I think, Levangi. And I think the article was published in 2000, year 2000. So we do this one. We do a standing flexion, sitting flexion, and we do supine to sit, and we do prone knee flexion test. So I'm going to demonstrate this. Okay. Maria, do you mind facing that way? Okay. So you can do a sitting flexion test. All you do is, I think we've demonstrated this multiple times. Very simple test. Okay. Okay. What you're doing is you're finding the PSIs, and all you do is ask the patient to just flex forward a little bit, and the hypomobile side goes up. Okay. Hypomobile side goes up. Okay. You can also do a standing flexion. I sometimes don't like standing flexion because if patient is in a lot of pain, their weight bearing pattern changes, and I think standing flexion test is not very reliable. But I think just for demonstration, I think I'll show you what patient does. Do you mind coming this way? Stand here for me. Okay. Okay. So what you do is same thing. You keep your hands on the PSIs. Ask the patient to lift up the right leg. Okay. Okay. And then ask the patient to lift up the left leg. Okay. Can you go higher a little bit? Yeah. The ideal response is the PSI should drop down. Okay. And the positive test is the hypomobile side goes up. Okay. So in this situation, I think if you saw both PSIs went down with hip knee flexion, and in sitting flexion, both PSIs did not go up. Okay. Another test we do is supine to sit. And sometimes it's hard to do this because if patient is in a lot of pain, you'll have difficulty. Lay on your back, please. Okay. So, okay. So patient is in supine. Okay. You test the leg length, and you ask the patient to sit up. This may be very, very difficult if patient is in a lot of pain because I don't think they will be able to do flexion from supine position. So the alternate test is, the alternate test is you just do a prone knee. You can palpate the medial malleolus, compare side to side length, and then you do knee bending. Okay. The interpretation is same. It doesn't matter whether you do supine to sit or you do prone knee bend. Okay. These are the findings from day one. Everything was positive on the left. Sitting flexion test, standing flexion test. Supine to sit was short to short. Okay. And prone knee flexion was also short to short. So you're finding these things. I mean, you're finding short to short. If you have attended our lectures before, the first thing that will come to your mind would be an upslip, right? Short to short. But in her situation, it was a very unique situation. We palpated the sacral base on the left, and I'll just demonstrate it from the. If you have difficulty seeing it, just let me know. Okay, so we palpated the sacral base. You find the PSIs. You go up 45 degrees. You palpate the sacral base. She was very, very prominent on the left. and the dorsal SI ligament was extremely tender. Okay. So I've done this for a long time, so I can actually assess it very easily, but there is a way to assess innominate. Lay on your back for me, please. So we were finding something called as unilateral sacral extension on the left, and we were finding something called as pelvic inflare, because if you know, unilateral sacral extension can occur with pelvic inflare. The best way to assess pelvic inflare, which I will demonstrate, the best way to assess pelvic inflare is you take a tape measure, you find the xiphisternum, okay, and you measure the distance from xiphisternum, okay, if you can see, to ASIS on one side, and then you do the same thing on the opposite side, okay. With inflare, the distance on the inflared side should be shorter, okay. So this should be sitting like in a kind of a closed position, okay, should be like more medial, okay, on the affected side, okay. So if you've ever treated an inflare, those patients are complex. I've seen like few, and usually patients are very, very symptomatic, highly symptomatic, and just like her, basically. I think I've seen like few, and they suffer, and I think it's important to be able to address inflare and assess inflare. So I'm going to demonstrate this again. If you're looking for inflare and outflare, you're measuring the distance from xiphoid process to the ASIS, and you compare it to side, okay, and you will find that the distance on the affected side should be shorter, or distance on the inflared side should be shorter, okay. But if you see, I mean, this is the interesting thing here is that none of this explains, because none of this explains symptoms in the tibia. So pelvic findings, innominate findings, they do explain symptoms in the back, in the hip, but none of this explains symptoms in the shins, okay. And that's why I think most physicians were confused why she's having pain in bilateral shins, because none of this explain symptoms in bilateral shin. Anybody has a question? Okay. Okay, so I was confused on day one why she's reporting so much numbness, tingling in the shin, and I think the answer to that question is no, she's not getting L4 compression, because L4, L5, L3, L4 seem normal, okay, with palpatory exam, okay. So the answer is I started hunting for pubic symphysis, okay. So I'm going to actually show you how to palpate pubic symphysis, and then I will also show you saphenous nerve tension, ANTT, because I think she was getting a bilateral saphenous nerve compression, and that explains, and that is not very common, that you're getting a peripheral nerve entrapment bilaterally, okay. So this is not very common, because she's getting a peripheral nerve entrapment, saphenous nerve entrapment bilaterally, okay. And I started hunting for pubic symphysis, and I'm going to show you how to palpate pubic symphysis, and then I think we'll go from there. Mariana, back. And when you're palpating pubic symphysis, I think you have to be extremely cautious when you're doing it on the opposite gender. Yeah, I don't go hunting there. I just use. I'm going to actually move this closer so that you guys can see. Yeah. Okay. So what you do is you use patient's hands, and then you palpate pubic symphysis. Okay. In her situation, I was finding bilateral tenderness, like pubic symphysis were extremely, extremely tender bilaterally, and left side was inferior and deep. So left side was inferior and deep, and right was superior and prominent. And if you visualize it, Okay, and I'm going to try to make you visualize this, okay, on the skeleton so that you understand what I'm talking about. And that's why this patient has a higher level of complexity, misdiagnosed multiple times. So this is the skeleton, right? Okay, inflare is when your ASI moves medially, right? Okay, just look at pubic symphysis and tell me what will happen. Okay, so this is the left side and it is moving medially. This should go inferior and deep, and that's exactly how she was presenting. And she was extremely tender bilaterally. Okay, right side was superior and prominent, and because of this severe dysfunction in the pubic symphysis, the adductors become really hypertonic, and that causes saphenous nerve tension, and that's why she was feeling symptoms in the tibia or anterior tibia or the shins. Okay, so now you're dealing with innominate dysfunction. You're dealing with a dysfunction in the SI joint. You're dealing with dysfunction in L5S1. You're dealing with dysfunction in the pubic symphysis. Okay, and I think when I assessed pubic symphysis, then I understood why she's getting these bilateral numbness tingling in the shin, because she was getting this compression in the adductor muscles, and that explained her symptoms in the shin. Okay, I'm going to quickly demonstrate. There's a question here. We'll talk about the treatment. Okay, don't worry. Okay, I'm going to show you how to test for saphenous nerve. Okay, it's very simple. There's a saphenous nerve tension test, or saphenous nerve ANTT, okay, which I will demonstrate. Okay, and Maria, lay on your stomach, please. Okay, and so the best way to test is patient is in prone lying. You look at the foot position, that is important. You abduct the hip because the nerve is on the medial side, and you do a dorsiflexion eversion, okay, and see if you can reproduce patient symptoms. Okay, you're doing abduction, abduction of the hip, dorsiflexion and eversion of the ankle, okay, to test for saphenous nerve tension. Okay, and she was positive bilaterally, and that explained why she was presenting with symptoms in the tibia, in the shins. Okay, and this is a higher level of complexity. So because she's presenting with so many symptoms, you have to address every layer of symptoms. And it took me a while to actually get her going, because she was showing so much muscle inhibition because of all the multiple sites of pain. So I'm going to go to the next slide and show you. Okay, I assessed the hip. You can see that she has restriction in the hip. I was also suspecting a labral tear, but she tested negative for all the labral tests. I think we ran a cluster of labral tests. I think we can talk about this in some other lecture at some point. Okay. Look at the glute strength in the gluteus maximus, medius, and hip external rotators. Okay, and she's the person who works out all the time, and so see the strength. I think she's getting like this severe inhibition in gluteus maximus, gluteus medius, and hip external rotators. Okay. These are all the dysfunctions I found. I found a L5S1 closing dysfunction. Innominate dysfunction was inflare. She had a sacral dysfunction. She had a pubis dysfunction bilateral. She had a lot of restriction in the left hip. And then she had a hip musculature dysfunction. So she has, and that's why this level of complexity, she had a higher level of complexity because she was presenting with dysfunction at multiple sites. Okay, you're seeing that. So if you have to fix this patient, you have to make sure that you address everything. You address the L5S1, you address the innominate, you address the sacrum, you address the pubis, you address the hip, and then you address the hip muscles. Okay. Okay. So treatment is important here. I think I'm going to talk about treatment. Any questions till now, guys? We'll post this on YouTube so you guys can go and watch it again. But the idea is that this stuff is complex. Okay. Which book to refer? I don't think there is a book that can teach you this. I don't think there's a book. I would encourage you to go through our program, not trying to be a salesman, but I don't think any book can teach you this. This comes from research, literature, okay? A lot of fellowship training, and I don't think any book can teach you this. Yes, you can find some treatments here and there. She had a sacral extension on the left. She did not report a lot of right-sided symptoms. She did not report a whole lot of right-sided symptoms. So, I mean, yes, ILA is relatively prominent on the right, but she did not present with a lot of symptoms on the right side. Everything was on the left, and most of the symptoms were on the left. She had some low back pain, centralized, which I think can be explained by L5S1, being sitting and closing dysfunction on the left. But her symptoms were more like central and central left. Okay, and that bilateral numbness tingling is coming from the second pubis dysfunction. I was actually very, very surprised how tender the pubis were on both sides, just not on the right, not on the left, both sides. And she was sitting in a very severe pubis dysfunction, and it took like few sessions to address that. Okay, I'm going to quickly show you the treatment. I mean, we teach some treatment sequence, but I mean, I think the idea is that you have to address it regardless of what you treat first. You can treat pubis first, you can treat innominate first, you can treat sacrum first. Some of the literature says that you should treat pubis first. And I think in my experience, if I don't treat pubis, symptoms or dysfunctions usually come back. So I think the best way is to treat the pubis first, okay? Try to align the pubis, and then go on and try to align the innominate, and then try to align the sacrum, okay? So I'm going to show you how to treat the pubis first. And this is the pubis dysfunction MET. There is a generalized MET, but I think when you're seeing patients who are very, very tender and sitting in severe dysfunction, I think it's important to be specific. And this is a technique for inferior pubis dysfunction. Maria, lay on your back for me, please. So what you're doing is, if you're treating the left side, you stand on the opposite side, okay? You're holding it here, okay? You're pushing the pelvis superiorly, and you're asking the patient to resist extension, okay? Asking to resist extension, and this is how you correct inferior pubic dysfunction, okay? Okay. Okay. She also had something called as a closed abduction dysfunction, which means that the affected side is sitting deep. If I have to explain how it will happen, going back to the pelvis again, okay? So your innominate is sitting in something called as inflare, right? Okay. What it will do to the pubis is the pubis will sit deep, right? Because I'm closing a book, right? I'm closing a book. It's also called as closed abduction dysfunction. This is sitting deep, okay? Your adductors come from your pubis on either side. They become really hypertonic just because the muscles are trying to compensate for this joint dysfunction. And then they entrap the saphenous nerve. When they entrap the saphenous nerve, you're gonna have symptoms of numbness and tingling in the middle knee in certain situations. Dorsum, I think at one point of time, she was also reporting pain in the arch. So that explains what is happening. So inflare is happening here. This is the pubis is becoming deep, okay? So we're trying to treat something called as a closed abduction dysfunction. Very, very simple, very, very simple stuff. If you know the MET, it's very simple MET. Lift the leg, okay? And you're trying to resist. Okay? You're trying to resist like adduction. Don't let me push you out, okay? You're trying to resist adduction, okay? Trying to resist adduction. You can try it in external rotation. You can try it in medial rotation. Wherever you find like a lot of muscle activation, you can choose that position, okay? The interesting thing in this is that you can treat the affected side, which was left, or you can do the exactly opposite METs on the opposite side. In her situation, it took us a while to address the pubis, okay, because of the severity of the dysfunction. Can you explain why pubis went inferior? I mean, I think you have to visualize this. I can talk about this. So, yeah. Okay. This is your ASIS, right? Anterior nominate is this. Inflare is when ASIS goes like this. Okay, when ASIS goes like this, actually it goes towards the pubis, causes the pubis to go inferiorly and deep. Okay, muscles come from the pubis, right? Your adductor muscles come from here. Whenever the joint is sitting in dysfunction, especially your pubic symphysis, we have always seen that adductors tend to like become hypertonic, okay, because they're trying to stabilize the pubic symphysis. Okay, because adductors are trying too hard, they're catching that saphenous nerve that goes through the adductors to supply the medial side of the leg and the foot. Okay. Okay. And that explains that these symptoms are coming from the pubic symphysis dysfunction, because once I was able to address this, her numbness and tingling became kind of random, not consistent. So she was getting like a lot of numbness and tingling, and then she would get like sporadic episodes, but not consistent. The interesting thing is she was getting bilateral pubic symphysis dysfunction, bilateral adductor hypertonicity, and bilateral saphenous nerve entrapment, which is not very common. They're very, very rare. And that's why it confused a lot of physicians why she's having these bilateral shin pain. Because if somebody has pain in the shin, medical doctors would look at L4, right? Because L4 nerve root supplies your shin. Okay. So it was not a nerve root problem. It was a peripheral nerve entrapment, bilateral. Okay. Okay. So I think we have shown this MET multiple times. I'll just show this one more time. I think we do this all the time. If you have attended our lectures before, this is the MET we use to correct unilateral sacral extension. And then I'll just quickly demonstrate these two techniques. Okay. Lay on your stomach for me, please. Okay. Okay. So I was finding sacral base to be prominent on the left. So very simple, straightforward. I think we've shown this so many times in a lot of our lectures. Very simple. You push on the sacral base, ask the patient to contract. Keep one hand on the ASIS, and all you're doing is pushing. Okay. And then relax. Okay. Push down. 1, 2, 3, 4, 5. Come back. Push down. 1, 2, 3, 4, 5. Yeah. Yep. And then you can finish it with sacral manipulation. I'll show you this. I think we shot this in Bombay when we were teaching the class. And the idea is that you do this distraction and thrust with extension bias, which means that you do a little more extension. And the patient we are treating here is also had a unilateral sacral extension. So I just want to play this video, and then I'm going to demonstrate this again. Okay, so you see hip is an extension, and you're trying to get that interior SI joint because that was not gliding smoothly. I'll play this again. Hip is an extension, abduction, internal rotation, and you're just trying to do like a kind of a extension bias thrust. I will show it on her. Okay, and there is a 1% technique we can do. I get the bed to the lowest position. Yeah. Okay. So I usually use this. Yeah. This position. I keep my hand in the sacral base. I can create a little bit of extension. This could become harder if you're not tall enough. Okay. And you can just do a thrust like this. Yeah. You can do a 1% technique. Yeah. We also have to address L5S1. I'll quickly demonstrate this technique. Okay. I'll play this video. I think we teach this manipulation in our hands-on. all the time because this is such a handy technique. Okay, so I'm blocking, my one hand is on L5 and I'm just opening it up. Okay, very, very simple technique. I'll demonstrate this one, okay, very quickly. Lay on your left side. Lay on the right side, please. Yeah. Scoot towards me. Okay. So patient is in side lying position. You find L5 and you turn till you start to feel L5 moving. Okay. L5 S1 is easy because you have sacrum as a whole block. You find the L5 spinous process, and now you're pushing towards the table. Okay. Pushing towards the table, you lean the patient forward towards you. So now you're on top of the patient, and now your force should be coming like this. So you open, and it already went. Simple. Okay. 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 I'm going to talk about what exercises we have done. So when I started seeing her, the strength was around three. Most of the hip muscles were around 3. Okay. But having worked with her for a few weeks, we have advanced our exercises and we have made the exercises much, much more challenging. So this is where we are. We're doing hip thrusters. You can see the amount of challenge she's doing. This is a good glute activation exercises. She's doing it on a Bosu. Okay, getting good core activation. Okay, and the idea of doing this is that you can get this exercise or glute max activation throughout the complete range. Okay, so very good exercise. I think great exercise for glute max. This is definitely an advanced version of a bridge. Okay. Okay, and then we did like some hip 3-way where she's standing on a foam and she is abducting, extending, okay, in different directions. Okay, so she's abducting straight, then she's abducting at a 45-degree angle, and then she's extending. Okay. We're doing some clamshells with side planks, which is another, if you know your force couples, okay, we are trying to activate the external oblique and internal oblique on this side, and then we're activating posterior gluteus medius on the opposite side. Okay. Okay. And then we did fire hydrants. This is another great exercise to activate the gluteus medius. Okay. Great exercise to activate gluteus medius. We did some squats. And this is week, probably you can say week 12. Okay. So I think I've worked with her for a while. She definitely we're not ready to do this initially. I mean, I think we were doing simple stuff initially, and now she's able to do squats. She's doing tandem walking, seems very happy in this picture, doing it. And then we started doing some step-ups. And this is a good exercise to activate the posterior chain, because if you know what the posterior chain is your gluteus maximus and opposite latissimus dorsi. So she's activating the gluteus maximus on the left, and because she's holding a weight, she's activating latissimus dorsi. And this is a posterior oblique chain activation exercise. Okay. I like some coordination exercises. Okay. Okay. We're doing some side step ups because I like to activate the gluteus medius in standing position, very functional. Okay. Okay. You can try different exercises. The idea is to stabilize the SI joint, stabilize the pubis so the dysfunctions don't come back. She's done pretty well. I think the last time I saw her in dysfunction was probably a month and a half ago. She's done well, and she's, I think, getting stronger. She went to California, did a long hike without much pain. So I think she's getting there where she's going to get rid of me. Okay. So these are some of the exercise ideas. But the point is, exercises will become easier. Point is that you do this part. You understand why she's having symptoms at different sites, why she's having low back pain, why she's having hip pain, why she's having numbness and tingling. And that's where clinical reasoning is the key. No, I did not use Bosu and foam in the first in the first and second session. I think in this, I think the idea of using Bosu and foam is to activate core activation. That's the idea. So once your exercises once patients develop good strength, or they are doing like at least 3+ or 4, they can tolerate good resistance. The idea is to improve core co-activation. So they can activate the hip and they can activate the core. So that's where the level of challenge comes. We add like a Bosu or unstable surfaces so that they're activating the hip, but they're also activating core musculature. Yeah. 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 So once you develop good hip strength, I think the idea is that they're able to activate core with every exercise. Okay. Or trunk musculature is a better term than core. I can demonstrate hip 3-way. You can do nerve sliders. I think with cutaneous nerves like saphenous, what I've seen is nerve sliders. I think the idea is that you treat the underlying cause. The underlying cause was she was getting this severe pubis dysfunction. I think you have to address it. You can definitely teach them nerve sliders. You can teach them self-METs, it doesn't hurt. Okay. I will demonstrate hip 3-way. I'll ask, do you mind demonstrating this one? Where you stand on the foam and then do this one. Okay. Use this resistance. Just stand on a foam. So my friend here will demonstrate hip 3-way. Okay, and you can squat a little bit. So she's doing a little bit of abduction, and then she's going at a 45-degree angle, and she's doing the hip extension. The idea is that she activates posterior lateral hip muscles, and then she can do it on the other side while she's stabilizing on the right. Okay. Ideally, I like to do it on both sides because it gets the isometric as well as concentric and eccentric. Okay. Okay. Because she's standing on the foam, she's going to activate some trunk musculature. Okay. Okay. Thank you. Okay. So the last time I saw her was like, I think 2 weeks ago. This was the reevaluation I did. Her pain was mostly not there, but by end of the day, she would feel 1 or 2 pain. Okay. No back or hip pain, but with long duration sitting, like if she sits for 5 to 6 hours, she gets like some achiness, 1 or 2 pain. Okay. So I think we've managed it decently because most of the time she does not have symptoms, but endurance, I think we can still work on endurance a little bit so that she gets like really, really strong, and she has the symptoms she's feeling at the end of the day also becomes better. So this is lumbar range of motion. You can see was good. Left side bending is still a little restricted. SI mobility can improve a little bit. Okay. Gluteus maximus strength, you can see, is very good on the left. It almost matches to the right. Okay. Tenderness on the dorsal SI ligament is still very, very mildly tender. I think there may be some wear and tear in the ligament, I think, or maybe some calcification, because I feel like she was sitting in dysfunction for a long time. Okay. 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 SI testing, you can see all 5 tests were negative. That's a key. Okay. So compression, distraction, Gainsaline, thigh thrust, sacral thrust, everything was negative on the reevaluation. Okay. I did the palpatory findings, negative for lumbar dysfunction, negative for pubis dysfunction. She reports numbness once in a while, but no consistent numbness. I think she said that she had like one episode of numbness in a week, only on the left side, if I'm right. Okay. 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 So that's it, guys. I think if you have any questions, please feel free to ask us. Okay. I'm going to stick around for a few more minutes. And the idea is that manual therapy is not about popping and cracking. Manual therapy is about understanding what's going on, what needs to be treated, understanding. I think clinical reasoning is the paramount. Okay. Okay. Understanding why a patient is experiencing certain symptoms, and to be able to clinically correlate it is the name of the game. We run a 12-month program. I think we're starting with cohort 3 next month. We already have a cohort 1 and 2 running. You can attend cohort 3.0 online or offline. We are teaching in Bombay in, I think, November, when we do our 7-day hands-on. Okay. I did not teach any self-METs, but you can. I saw this patient 2 to 3 times a week consistently for almost 3 months. So she had a lot of multiple dysfunctions. So I think the frequency was a lot. I think I've seen her for almost 3 months, 2 to 3 times a week. Okay. Because when you're treating with like multiple dysfunctions and a lot of muscle inhibition, hip dysfunction, SI dysfunction, L5, S1 dysfunction, you definitely need more intervention. And I mean, at one point she was advised surgery. At one point she thought that she has like a massive disc herniation and she won't be able to be active for rest of her life, which is horrible to tell a 24-year-old. Okay. Another thing I think I forgot to mention here, the last session when we did the re-exam, okay, we tried some running and she was able to run short distances. She was able to do stair climbing without much pain. Okay. So the idea is that you develop this level of understanding because it's all problem solving. If you know what you're treating, I think the game becomes easier, because every symptoms patients tell you usually have an anatomical correlation. So the idea is that whether you're picking up those cues or hints patients are giving you, if you're able to pick that cues and hints, I think you're able to come to a clinical conclusion, a clinical diagnosis, and able to help your patients. Okay. So, and it requires some time and effort from your part. I was able to differentiate between L4 because I think L4, L5 was not in dysfunction. There was no segmental restriction at L4. Yeah. Okay. And if it is a nerve root problem, I think I'm going back to, I think it's a good question. So you don't make a diagnosis based on just one test, right? So, okay, just going back to the day 1 exam. Okay, look at the day 1 exam. This is the day 1 exam. Flexion was not painful. If we know that if there's a nerve root issue, flexion should be painful, right? Flexion was not painful, not a lot of restriction, but around 75-degree flexion, no painful. And then you can also combine this with your palpatory exam. L4, L5 mobility seem normal. L3, L4 mobility seem normal. That's where your L4 nerve root should catch, right? Or should get entrapped. Okay, so if it was a nerve root problem, L4 nerve root problem, dorsiflexus should be weak. Okay, seem more like a numbness and tingling issue more than a nerve root issue. But getting a bilateral saphenous nerve entrapment is not very common. And it's also on your gut feeling. If you're a clinician who's looking for stuff, I mean, I think I'm looking for problem solving, I think you tend to find right things. The first time I palpated pubic symphysis, I think she said extremely tender. Yeah. So there was a question between whether it's a L4 nerve root issue, bilateral compression. She's 25 years old. You cannot find like a spinal stenosis, bilateral central compression of L4, right? It's kind of highly unlikely, right? So there are other factors in. I mean, you will not find bilateral symptoms in a 25-year-old. One would always think spine first. Yes, absolutely. You're right. But I mean, bilateral symptoms where? That's the question too. I definitely, we know that if it's a spine issue, flexion, if it's a disc issue or not herniated issue, you should have some restriction at that segment. You should have restriction in flexion. Flexion seemed not bad. And I was not able to reproduce any symptoms with flexion. Okay. And another fun thing is, I think there's another cue to this is she also reported like seldom symptoms in the arch. If you know the saphenous distribution, saphenous supplies your medial knee, medial leg, and your arch. So that there was a hint there when she was coming. So she would report like that her arch cramps up sometimes, and that I felt like was coming because the saphenous supplies your arch too. If you look at the plantar distribution, I mean, saphenous supplies the medial plantar portion of your foot. Okay, and so that's where the hint was. Okay, and I think definitely you can do a L4, L5 segmental mobility, L3, L4 segmental mobility to actually rule it out. Okay, any more questions, guys? The idea is that whenever you're seeing patients with symptoms and radiating symptoms down the leg, just don't assume that it's all coming from the spine, because yes, symptoms can radiate from the spine too, but I think make sure that you're always looking for peripheral nerve entrapments, because those are common too. If you have biomechanical dysfunctions in pelvis, pubis, around the hip, you can have peripheral nerve entrapments in the lower extremity. Okay. Any more questions, guys?